Hello and welcome to the Nurse Rosa's Insights podcast. I'm your host, Rosa Hart, and today I get to interview one of my mentors, Dr. Gauhar Chaudhary. Thank you so much for being with me today.
Thank you for having me. I appreciate that.
Yeah, got to see you virtually because you're far away in Montana now.
We are, far away. At least, 23 hours away driving. I've done it, so yeah.
Oh, dear. Yeah, let's not drive that far. Gosh. So I invited you here today because on the Nurse Rosa's Insights podcast, I like to ask healthcare stakeholders for their perspective on the state of healthcare, where it's at today. And then at the end, we will go to the billion-dollar question on how you think you'd like to see it fixed. But let's get into some of your background and how did you get into working in healthcare and really inform your story?
Yeah, so it started actually as a child when I had severe asthma as a child, and I was hospitalized almost on a regular basis, at least once or twice a year. Even as a toddler, I still remember those memories. And I guess I just seeing growing up, being in the hospital, admitted to the hospital for asthma attacks, basically severe asthma attacks, just seeing all the doctors take care of you, the residents, I was just fascinated. And I'm like, I want to do that. And that kind of that's what started this whole pathway. Although I didn't choose pediatrics, I ended up going into neurology. Yeah. Or pulmonologist, that's right.
Respiratory at all.
Right. And so during medical school, when I was doing my rotations in radiology, I loved looking at the brain images, especially MRIs or CTs. It was just fascinating and just came easy to me. And so I thought about radiology at one point, but I don't think it was for me because I do like interactions with patients. I'm not saying that radiologists don't, but like kind of a more continuous interaction with patient population. And so neurology was the best fit. And so
how did you get into neurology? Did you get randomly assigned to it and get surprised kind of like you did with radiology, or?
No. I mean, I enjoyed my neurology rotation. I enjoyed my radiology rotation, but actually I did radiology even before I did neurology. And so I think when I did neurology, it was like, okay, this is a better fit. Right. I ended up getting accepted to the University of Kentucky for a neurology residency. Did 1 year of internship medicine, 3 years of residency of neurology, which was pretty hard. Especially second year was pretty tough. But we had excellent teachers, excellent senior residents that kind of helped us through. And then I did 1 year of vascular or stroke fellowship at the University of Kentucky. So, and then from there, I came to Louisville, Kentucky, and that's where we met I was at Norton Brownsboro Hospital. Right.
Well, actually, I think we met in the middle of the night when I was downtown because you were covering stroke call for the system.
Yeah.
I remember because I was a new baby nurse and I would call a stroke call in the middle of the night, and you were the one who would not yell at me, and that was really nice.
Yeah. I understand what people do, but we're all this together. So
exactly. Well, and also like as a new nurse, like unfortunately we don't get a fellowship or something to later on our own knowledge.
Absolutely,
like we have a lot of learning on the job, and so that's why I call you one of my mentors, because you really taught how to do a neuro assessment, even like talking me through it over the phone, which is more than just not yelling at somebody. It's
no.
What do you look for? What does this mean? And taking that teaching approach in basically all the interactions. And so I felt like that's kind of what really kept me in neurology was the attitude of the only dumb question is the one you don't ask, because you need to know the answer to best care of the patient. And I really love that whole approach. And that's one thing that really impressed me, like as an ICU nurse, seeing all the different specialties, the neurologist had to hear the patient's story usually in order to make diagnosis, like, yes, you need a scan. but you need a physical assessment and you need to hear their story for the context of their symptoms. And so I really, really appreciate that.
I had excellent mentors too, so I kind of pass it on. So
like Dr. Jessica Lee.
That's right. Dr. Jessica Lee was Dr. Lee was an excellent mentor. At one point, I remember I was thinking about neuro-oncology at one point, and she convinced me to go to stroke, and I'm glad she did because it was the right decision for me. Neuro-oncology is great too, but I think it was a better fit doing stroke for me. I do like the dopamine or adrenaline rush a little bit you get for stroke. Trying to figure out if you can reverse these stroke symptoms. Is there a large vessel occlusion that we can take out and do amazing things? And so that was a better fit for me because it was amazing to see all these amazing results.
Yeah.
Dramatic improvements, like almost sometimes rapidly, actually. So I guess in many cases. So.
Definitely. I mean, I love to say stroke is the thing in neurology that is not a chronic degenerative disease. It's something that can be reversed and fixed.
Right. Absolutely.
There's so much hope in it, and there's so much we can do to prevent another one. And so all this education that people in stroke do is from the knowledge that it can make a very huge difference. So, and we see it.
Right. It's a balance between lifestyle and also medications, right? It's not just one. It's both, really, too.
Well, and everybody's different, right? So they might to do different things. And so I know you said you like to put those puzzle pieces together. But as you mentioned, you started working in serving the populations of rural Kentucky, and now you're serving the rural populations of Montana.
That's right.
So what would you say would be some of the similarities there, and what would be some of the differences?
I guess similarities are, there may be some small access hospitals. There's probably more differences than similarities. I guess you could say that maybe the patient population in the rural areas are very similar, like farmers, ranchers, maybe. Is very similar in these smaller communities. I think probably one of the similarities. And I think so key differences I would say is, I think in Kentucky, they probably have a little better access to hospitals because there's more probably denser network of outside hospitals besides Norton and, of course, University of Kentucky, which are the hubs. Here, though, it's much different. When I first got here, there was no comprehensive stroke center. You were just a primary care, primary stroke center. That was it. So if a rural hospital gave TPA or at that time, they would send them over to us. But if they had a large vessel, there's nothing, we couldn't do anything about it. They would have to ship them straight to, they would have to go to Denver. And so.
But they do that within the time frame?
For a large, so they would get, depending, they would probably get TPA if they were candidate for that at the local critical access hospital. But if they also had evidence of a large vessel blockage, then they would have to fly straight to Denver. And I think Denver from Billings is roughly like an hour and a half flight.
On a helicopter or fixed wing?
No, on a fixed wing. So that's another key difference is distance. Kentucky is a lot smaller than Montana. So we have a lot of fixed wing flights from all over Montana and Wyoming. We have to include Wyoming too, because we cover almost a half of Wyoming. And so, and weather is a big difference here too. So, there are some weather issues in Kentucky, but probably not as frequent as they are here. Like here we get bad snowstorms. And so, you could have a large vessel occlusion and a post-TPA patient sitting in access hospital until, the weather clears up and they can fly him in, right? It has to be safely done. And there's not enough flight crews, unfortunately, so sometimes they got to wait. But yeah, they do their best, and the flight crews here have been, and the ground crews too, have been amazing. They do an amazing job keeping that penumbra open, or at least as large as possible until they get here. And we still see dramatic things, even if there's a delay. There see some really great improvements. So
it's always worth calling 911, right?
Yes, right. Although, over here, though, I think you talk to a lot of patients, they live maybe 10 miles away from the local access hospital. And so they will just take their family members having the stroke-like symptoms. They'll drive them to the hospital because it's faster than waiting for an EMS crew to arrive to them. So
yeah, can't really fault them for that in some cases.
Right.
Now, did I hear you have a lot of like volunteer EMS crews in Montana?
I think we do. Probably in the local communities, probably, yes. That's a very good question. I don't have the numbers for that. Here in Billings, of course, we have, I think it's called AMS, American Medical Service, or it's called AMS, so I apologize. Maybe I have the.
But that's like that's what's available in town.
Correct. And then we also have a fire department. They have their own medical crews too. So, yeah.
Like here in Kentucky, each individual county is responsible for like funding and staffing their own EMS. Right. And so it's not like synchronized across the state.
Right.
But I'm not aware of any that are volunteer operated and run.
Right.
And staffed. I know the firefighters are, but I don't think the ambulance crews are in Kentucky. But we do have areas of Kentucky that it might take 2 hours for an ambulance to get.
Right.
Due to lack of humans to put in trucks, or let alone lack of trucks and those little roads on the hills. So
I remember when I was there, Evansville, Indiana was one place. I think they would have some coverage sometimes, but they would have a neurosurgeon that could do their stuff. But when they were not available, I think it was like a 2-hour rotor flight, helicopter flight. Yeah. So.
Yeah. So, well, and I wanted to ask you as well, like coming from growing up in Canada and benefiting from the healthcare there a lot, like you did as a patient, being here and serving in the United States healthcare workforce. What do you see as far as like any benefits or as for one over the other?
I mean, there's pros and cons for both. I mean, of course, I just would, for me, it was just, just seeing a primary care doctor in Canada growing up. So that was, I mean, it was pretty quick. I could see them pretty quickly. I think, and if you were to look at that from like more like a stroke standpoint or just neurology standpoint, I think that
you wouldn't have had a stroke standpoint as a child.
Right. But just talking to patients, because we do get Canadians over here, because we're not too far from Canada, actually, right?
Oh, that's true.
And I can give you some, I'll give you 2 examples, actually, because we get a lot of tourists here, right, to Yellowstone, which is only about 2 hours away, if you're 2.5 hours away. But I had a patient here who, they were from France, was a couple from France, who he fell, had a bleed, and had a seizure, or the seizure, came first, then had a bleed. And sorry about the dog, I apologize for that. And they lived in Lyon, France, and apparently has one of the premier, from what they told me, one of the best neurological hospitals in the country. It's not in Europe, but their husband was having issues, I think, with some other prior issues, like maybe syncope or some waxing waning symptoms, and when he came to the hospital, we did all the standard stuff, CT, CTAs, MRI brain, even an EEG on him, if I remember correctly. And they were so impressed that all that was done like within less than 24 hours. Over there, it's basically social medicine, it's medicine that's more administered by the government, by the state, I guess. So I guess costs are looked at very carefully. But yeah, I think, we can get stuff a lot done faster, but I think it's probably more expensive here than other places,
right?
Yeah, right.
You'll be alive to pay the bill later, right?
Right. But then again, a lot of people do go bankrupt because of medical bills here too, right? And so there are pros and cons. So.
Well, and that, we'll talk about, is healthcare a human right as an idea, right? Which is usually used to support the idea of having the government covering all the medicine and not having it privately funded and on a more competition model. But at the same time, I could see how that could create its own set of issues out in like a rural area. Like, how are you be able to provide the same level of service qualitatively, which is what we try to do. We measure all our quality measures where we're trying to get everything done as quickly as possible, but also as accurately as possible. And how are you supposed to give that to somebody in a rural area like you would in a downtown urban area where you've got all that infrastructure support?
Yeah.
So how do you see that conversation?
No, I agree with you. I mean, healthcare is a human right. But like, how do you do that on a practical level, right?
Yeah.
I think some things we could do is, I think telemedicine can maybe bounce that a little bit, although it's not as great as being in person, but it does provide some service at least. You can see a specialist that is not over there in that small little community, such as neurology or cardiology, or the various other services. Having better partnerships with them, I think. Education, going out there, educating the local physicians over there, making sure they have, they're aware of all the current stroke guidelines, provide them all the data, all the information, I think is important too. That's been very helpful. And we do that. Actually, we do travel. We've traveled through many of the hospitals, local hospitals in Wyoming, and have done stroke talks and have helped them with their stroke protocols, because they ask very simple questions like, do you do CTAs in all strokes? Because sometimes their radiologists don't want to do, because they worry about kidney function. But we always reiterate, at least, as neurologists, is that, neurons over nephrons.
Oh no, they probably don't like that, do they?
Probably not, right? I'm sure nephrologists maybe not happy with that. But in an emergency situation, we need to know. And, I think it's important, because yes, even if it's a TIA, I've seen situations where there's a TIA where they're back normal, but I like to do the CTAs. As long as the kidney function is decent and you can tolerate the contrast, we'll do it, because sometimes we find situations where they have a partial occlusion, maybe in the middle cerebral artery, that we'll have to watch closely, maybe even do some intervention. If we didn't do the CTA, we wouldn't be aware. And of course, we can also do MRAs or, MR angiograms, if it's not emergent and we can wait, we'll do that as well. If we're worried about the kidney function.
So that education of other professionals out there who competing priorities is really key. Providing that in the rural access hospitals.
Correct. So education, right? Reaching out to them. Sometimes we'll do even like, kind of like what we're doing right now, just do a Zoom call or a Teams call with their ER physicians. They ask questions, try to answer them. And sometimes, although we have to work on because of staff limitations, but like providing feedback for transfers. So.
Yeah, definitely.
Yeah.
So I think you kind of already addressed this as far as, like, would you say there's more like chronic diseases in the rural populations you see out there? Like, living in the stroke belt, we have really high rates of obesity, things like that. But do you see that as much in Montana, or are the populations more active overall? What do you think?
I see a couple of things. I see people not seeing doctors, so that, they're not aware if they have any chronic issues. We see that a lot.
Well, I do see that still. They're like, I didn't have diabetes and high blood pressure till I had that stroke and went in the hospital. It's like, you did.
Right. Or we see, there are people, they're pretty healthy populations, especially the ranchers and they're pretty healthy and strong people. But I think sometimes we'll see where, they're having maybe some mild stroke symptoms, but they'll just kind of like delay it because they think they'll get better. And so, unless, they have family members. But I've seen also occasionally where, no, you're going to the hospital, don't bring them right straight to the hospital, even though they come in reluctantly. But yeah, we see, it's not a high obesity, for my population over here, as we do see it more in the South. We do see a lot of strokes related to meth use here, which I remember that wasn't very common in Kentucky for at least when I was there last. Over 5 years ago. I think heroin was a big thing over there, but we do see a lot of some strokes from meth use, right? Because that can cause strokes as well.
Is that more recently of a development there?
No, I think it was here since I came here, so it seems like it's like a Northwest issue.
Well,
yeah, well, we see that a lot here too, right? But interestingly, the one do patients
prevention plan, right?
Yeah,
stop doing meth.
Right.
Do you have any good rehabilitation programs for people for stroke prevention?
There are rehab facilities here, of course, to help out with that. But, getting back to patients who don't see doctors, stop taking their medications, I usually will tell them that, if you don't see a doctor on a regular basis to kind of prevent this from happening in the first place, control your blood pressure, cholesterol, and all that stuff, that you're going to see a whole bunch of doctors all at once when you have that stroke.
Gonna make up for lost time.
Right.
I think you told me it was hard to find a primary care doctor, even for yourself, when you got there, right?
Yeah. Well, here in Billings, it's not as bad. There's more providership, but in the rural areas, sometimes they don't even have a physician. They have, MPAs and MPPs who do phenomenal jobs, actually, as well. They do really great jobs up there. But sometimes they leave. And so, you get used to whoever the clinician is, and then they leave or whatever, after a couple of years. And then, they don't like the new person sometimes. And so they just don't go to the doctor. And so,
Right.
I think it's common a lot.
People sign up for those like loan repayment programs where you work there a couple of years.
They do.
It pays for school loans and things like that. And so after that's over, their time commitment's done, right?
Potentially, yeah. That could be a reason too, or they just do a 2-year stint or whatever their contract says. And sometimes, they move on, unfortunately. So, but there's also a lot of physicians who've remained in certain regions for a very long time in Wyoming and Montana. So, and become like a bedrock for those communities.
Well, you've already been out there
almost 6 years. 6 years, yeah. 6 years in June.
In some ways, it seems like just yesterday. But
it does, yeah.
So what do you like the most about living and working there?
I do.
If you're going to convince other doctors to come out there and be primary care providers, right?
There's a lot of outdoor stuff you can do here. I don't hunt, but there's a lot of hunting over here if you like hunting. There's a lot of hiking, even here in Billings. Tons of hiking in surrounding areas. I'm about 1 hour away from the mountains. There's a nice little town over there called Red Lodge. We've gone there a few times. I think the community here are phenomenal. They're very kind people. They were very nice, of course, in Kentucky. I think there's a lot of similarities, actually. But the people are very, very, they're great, kind, and very patient, which is great. So
that is good.
Yeah,
that is good to have patience as a baseline personality trait for there.
Right. We've had people come here, like from New York, because we use locums occasionally, and they're from New York, and they come here, and I usually tell them like the patients here are really nice, and the families are phenomenal, and they just take that when I say that, but they're like, no, it's like, yes, you're right, they're so kind, and not just that, the staff too, because most of the people that work here are from Montana originally. So.
Yeah, I think I saw that the Billings Clinic is like the largest employer of Billings.
Correct.
So
we just recently merged with another system called Logan Health, which is Northwest. So we've become larger. So
does that mean, do you do more with their hospitals as far as their stroke care now?
They have also a stroke team, an excellent stroke team. Dr. Kurt Lindsay is their stroke director over there. Yeah, so you might have met him.
Last year at
phenomenal team, great person. I enjoy working with him a lot, and a lot of expertise in the telestroke space, among other things. And so it's good to get his input and expertise in that area too. So enjoy working with their team.
Yeah, they seem like a fun group. We all went to the dinner last year. That was really
That's right. Yes, it was fun. Yes.
So this brings me to the $1 billion question.
$1 billion question, yeah.
Yeah. So if you were given a grant, $1 billion to meet the needs that you see, how would you like to see it used strategically to have the most sustainable impact?
I think a chunk of it would go into research. I think coming up with new medication. I think they're trying to do this right now, but I'd love to see more medications that could be given outside of 4.5 hours, maybe even up to 24 hours, which would be nice with similar kind of outcomes. So I definitely give money for that.
Like expanding the window for T&K?
Yeah, for T&K, sorry, thrombolytics, correct, yes. Mm-hmm. I think a lot of it, a chunk would go into education, making people more aware of, like we talk about BFAS, among other things, being aware of what stroke symptoms are. Mm-hmm. So they do go to the hospital immediately and not wait and save more brain tissue, right? And I think So a third, and then the last 1/3 would probably be, especially for here and for maybe other rural areas in the U.S., is to develop a robust kind of like stroke network where smaller hospitals do have all the tools, if not neurologists, but at least maybe telestroke, all the stroke education protocols, so they know what to do when they do see acute stroke. So those would be the three main areas.
Well, that would make a huge difference.
Right.
And talk about sustainable impact. If you're able to reverse somebody's stroke symptoms, they come in and half their body isn't working, like they their arm, they be able to use their leg and might not be able to speak, and you're able to give them something through an IV that gives those abilities back. You're preventing disability for that person, any strain of financially and physically and everything on the family, preventing them from being on disability, which is their chronic health problems they can develop from the immobility that results from being able to walk, etc. Talk about sustainable impact.
Yeah.
Like, it seems simple to you and me, I feel like, and it's just, I feel like a lot of people just have no concept of how impactful it can be. So thank you for realizing that.
And I also like to say that a lot of what I know, especially with, telestroke, stroke education, and all the other aspects of stroke that we're not not all of it was trained maybe in residency. You learn kind of as you go. A lot of it thanks to Lynn Hunley, I think, who was a phenomenal, unfortunately she's not with us anymore, but she was a phenomenal force, a great person. I learned a lot from her. Even when I left, Norton, I was still in communication with her because I was actually at one point going to bring her here to help us build a comprehensive stroke center. But unfortunately she passed away.
Hunley? Oh, you mean to bring her
as a consultant? We were going to pair as a consultant. Yes, yeah. Not as we made that very clear to her. So, but yeah, she was a phenomenal person, and it's a great loss to the stroke community, I think, and in large. So she contributed a lot. It was an honor to know her and learn from her. So
definitely, yeah. She hired me into my current role as a stroke nurse navigator, which she hired me into that role. You recommended me. Thank you for that.
Oh yeah, no, I was you would have got it even without my
She said it was because of your letter, so
that was really kind of her.
I'm just gonna go really say I do whatever she said. But yeah, she really changed our lives and the trajectory of a lot of people's lives through improving stroke systems of care, helping to start Stroke Care Network, which is the part still going on between Norton and UK. So yeah, it really takes a village, and
it does.
So hopefully we'll keep making headway and getting the word out about what we can do in the community to be fast and stop stroke. Right.
Thank you for all you do. I learn a lot from you too, and it's always good to hear your aspects of stroke care too. So I appreciate everything you do.
Oh, well, thanks.
Thank you.
I appreciate you coming on today. And for our listeners, if there are anything you've learned today, I would really appreciate it if you leave that in the comments. Let me know if you know of someone else who has a $1 billion idea that needs to see the light of day, so that maybe it'll get closer to actually happening. And make sure you follow and subscribe if you're watching on YouTube, or if you're listening on an audio platform or through the Health Podcast Network. And I will see you in the next episode.